Thank you so much. So now can we have the microscope view? Virender, everybody noticed and so did I that when you make the main wound, you actually put a side port there and then make the main wound. So what is the rationale behind it? At least you did it in the first case, and this has also come as a question in the chat box. Can
I
we
will not I
can
will
we
not say it like that. It is a very scientific way, according to the teaching what we get. That ideal thing should be a three planar incision or two planar incision for the main port. But now I treat all ports like a similar ports because the incision size is reduced drastically from 3.2 to 1.8 or 1.2.2 or 2.4, whatever you do. What I realized gradually over it that majority of the time when you try to make sorry, three plane incision, it is not the three plane incision, and in that you actually end up either early entry, late entry, or whatever kind of thing. And with the MVR, what I am getting, you see that I am going in the cornea vertically almost up, and then I am dipping. So it is giving me some kind of seal wall effect even in one plane incision. And with this one plane incision, what you can see that at the end it is sealed one thing. And I would like to share another thing that many of the cases in whom we need to do a combined posterior anterior segment surgery, I am doing the same technique and wound is not leaking at the time when my colleague is doing a VR surgery together. So I'm not saying that others are doing wrong way or whatever way, not controversy, but I'm very, very happy with this kind of incision because it gives me almost an incision with the defined margins, defined length, and I'm very happy. And this started almost incidentally when there was some issue with my main port incisions. Knives were not very sharp, and I started making with them entry and then just enlarging with those knives, which were very, very not good, almost 12, 13 years back. And then I realized that this is the way I should go ahead because I'm getting more results. I don't know how much clearly it is visible. You can see this dimension of the wound is what we feel that almost two-thirds of the this width is this length, and this gives you a sealed incision at the end. But definitely it is not the way it is being taught or not practiced by everyone. You can see the fluid wave is passing. I'm just pushing the lens to see that completion is done. Just a gentle rotation as we could not do in the last high myop case. We didn't wanted to put any pressure on the jonules in that case. So we didn't try and we just aspirated out like a soft case cataract management we do.
So, Virendra, there's one more question. Is there, and I think that is for the manufacturers, is a toric available with iHands? I think as of now it is not,
Right now it is
but
not available.
yeah, but very soon it will be available.
I think soon within this year itself we are going to have the company people are here. If they can give me some data when it is going to be available.
Mr.
Any
Jasurvedi,
expectation
any
of
idea when iHands toric will be available? See, because for us, if I talk in our in government institutions, the difference between the price of a monofocal and iHands is really not much. And so all the patients who are able to afford monofocal are able to afford iHands with an extra advantage of being having to see, intermediate as well as near and, much more comfortable in the daily activities. So hence toric would be a useful tool in the armamentarium of surgeons because that would again make this product available to people who are able to afford it.
another thing I just want to highlight that many of the people are using sharp choppers for cases. I am using just dialer for all soft cases up to grade 3. Grade 3 plus only I use choppers. For the rest all patients I use dialers and I am happy. With not 100% recommendation from my side, but this gives an advantage that even if it gets touched with the posterior capsule, the rip off of the posterior capsule is less chance than a sharp chopper. Another thing when in today's world we are changing everything with every case. keeping many sharp choppers will add on some cost, and dialers are easy to use in majority patients. So you can have multiple dialers, and in a particular case only you can use that sharp chopper.
I think some very useful tips you have shown us today. One is the making the incision. Another, everybody is really, praising the way you showed the polishing part. That was very meticulously and elegantly done, Virender. I think that was again something to learn. And Dr. Satyajit Sinha is asking why premium IOLs don't come as preloaded. So I think that is a question for manufacturers to answer as to why premium IOLs don't come as a preloaded option, and they should come as a preloaded option because that would take another factor away, and that is factor of having to load the lens, and factor of microbial contamination of the anterior chamber, which theoretically may occur, although practically it doesn't occur. So again, that this case was also like a cakewalk for you, Virender. It's being done so effortlessly that you just, and I think this is the beauty of the machine. You just keep the phaco probe in the center, and everything is just coming automatically to its step, or maybe you are driving it to its step automatically. Very nice.
No, you are right that the machine gives a big advantage. Then, as I said, for Microsoft also, for machine also, having a good machine and good Microsoft gives you comfort in the OT. And when you are comfortable, you can deliver definitely the results.
So I think
Majority of the
that is a very good message to take, that your tools, because you are like a workman who's working with the tools, and the most important tool is the operating microscope as well as the machine which you are handling. And I think that one should not compromise and should try to get the best. So in this case you are planning to put a synergy lens.
energy lens. The difference I found with the synergy much more is that the multifocal lenses, they were having a good vision at a particular distance. So many of the time we need to teach them that please see at this distance. And sometimes that distance, if they are very habitual of keeping one particular distance, they were saying, though, I have to change my distance. So that was one reason that synergy is more accepted. The another thing is that the dim light condition multifocal were not very good. They were needing slightly kind of normal or more light. If there is any other issues with the multifocal, like on some dry eye or some corneal issues or some medical pathologies, right now with Synergy, though we have implanted very few, almost around 45, and but lighting condition is not affecting that much. So dim light condition vision is also there with the Synergy. So that will give definite acceptance by the patients more easily. And right now, very few, I think four only we have done bilateral. Rest all are only unilateral surgery done. But with the unilateral surgery also, they are feeling a kind of wow factor, which is a big thing, because initially what people were afraid of, giving unilateral only and avoiding almost for a month or so, patients are not ready for second eye, saying we can wait, we are not having any issues. So I am also not forcing them, but the company advises to do second surgery also very early. Sometimes for financial reasons also patient don't go for second eye very early. But I think when patient is not having any complaint, I am also not pushy. I can wait for second eye. Saline. Saline.
So again, that is an excellent demonstration of the way you're doing hydro polishing. Uh, I have a question, Virendra, for you. Now you have an option of iHands and you have an option of Synergy. So which patients you would say go for iHands and which patients you would say go for Synergy? Will it only depend on the affordability of the patient, or would factor in some other parameter?
Definitely the cornea need to be looked up very well. If there is some kind of corneal irregularities which you feel are going to give some issues with the some part of glare of multifocal, then we don't do. The topo is a kind of a basic routine workup for all cataract cases in my place, and that gives me a big comfort. If I see the topo is good, then my first advice to patient is for Synergy. Now Synergy, initially it was multifocal lens. Here I would like to just point out for the people who are still afraid of saline multifocal for the complaint of glare. Let me share, for almost few years, not a single patient is coming back and saying that, sir, I am having trouble because of glare. Though we do one good thing which we feel is very important, that we ask the patient to get a multifocal done, and when patient is ready for it, I say particularly myself that this is coming at the only one cost, that whenever you drive in the night you will see multiple rings, and if you are ready to accept it, then my choice is that you go for multifocal. And if he doesn't say anything against it, then I am confident of using multifocal. If he says, oh, this will give trouble, that you, then I say, then you think over it, but this is my advice. And if he comes out with the more questions, then I don't do multifocal. But if he doesn't come out with the questions, then he doesn't come out with the complaint also. So this is kind of a test I am doing. And my first choice is definitely a multifocal or Synergy now. And as you said correctly, if finance is the issue, then I don't push them. But whenever they accept, they really come and thank me that now they are feeling very, very good. So another thing I will say, which will be a controversial kind of thing, that I use main pot also for doing pollution sometime like this. Because this direction I was not getting for removing the fibers from both sides. So I tried another direction, and with that another direction, except these few fibers, the rest all are removed. So sometimes you need to push them or you need to polish them from different angles, because one particular angle they have a better addition on the capsule. So that is a way you can go ahead and do polishing all around.
So there's another question which has come up on the YouTube channel, that would you recommend eye hands or a Synergy for cases of diabetics?
100%, as I said before also, that diabetics, if they are not having a diabetic retinopathy, which are going to a edema kind of thing again and again, which compromises some of the contrast, then Synergy or multifocal can be some issue. And some of the issue pointed out by my VR colleague, that when you need an imminent VR surgery, then giving multifocal is not good, because when they want to do a laser in the peripheral part of the retina, they feel some problem with the multifocal lens, but rest all is very, very good. So I think we are, diabetic patient can go ahead with the Synergy, and I think there is no question, no controversy, no concern. IONS should be offered to all diabetic patients, irrespective of the amount of diabetic retinopathy they have, because there is no negative point for IONS in my mind. For IONS, if they have any particular thing in mind, then we can discuss. But I think IONS is no issue, no negative part. अंतर जी लाइट में देखना लाइट में देखते रहना बस
Can you just highlight some features of this Synergy intraocular lens, which you think, what are the advantages of this Synergy lens over say for Symphony? And of course we know that over eye hands, it does score over eye hands, but how do you think it is going to be different from Symphony? So how do you convert your Symphony patients to Synergy patients?
For Symphony, multifocal, trifocal, or common is the rings, and these rings, when patient wants to see them, are visible definitely. They will be there for life. They are not going to be not there. But the tolerance to the rings are there when positive mindset is there, and there are not any other issues which are increasing their bad effect of glare or halos. As I said, the dry eye should not be there. The cornea should be okay. Macula should be not having any issues with the contrast reduction, then all are acceptable. As you said for what you said initially,
So I said, how will you, I mean, what patient would you say, okay, you go in for Symphony, and then second?
Sorry, I forgot that name just only, that's why I want to say.
Or Synergy,
The advantage was that it was giving good intermediate vision, which was not there with multifocal lens. But near vision was a big, big concern. I did many of the patients in whom I did first eye Symphony and the other eye multifocal. or many of the patients I did Symphony as a second eye when I did first eye multifocal and they were concerned with the computer vision. But I think both can be addressed by synergy. So that is a big advantage, because the common problem was that either near vision was not there or intermediate vision was not there. I used quite a lot trifocal lenses also, but somehow I was not very happy with the trifocal point, because again the continuity was not there, and because of not having continuity and ask them to read on our choice of point was a big concern. And synergy, as they are marketing and is almost accepted by me also, that patient is doing their near work at their ideal distance. We are not forcing them to use them at a one particular distance. And when patient is not being forced to do the way we want, and if he has a freedom to do as he or she wanted, acceptance definitely increases. And this is what I am finding in my very short experience of almost 1 month plus, that the patient acceptance is very, very good for the distances, for doing their work, whether reading, whether doing computer work, mobile work, or whatever way you do. So you can see that now IOL is centered, and then we have to see that it should be at the end also centered. Here I would like to show one thing, that I use pilocarpine in many of these patients to make that lens placement comfortable, and at the end of the surgery itself to make the patient feel kind of a wow factor, that very dilated pupil, a patient with the rings will have some of the visual phenomena which can be avoided by reducing the pupil size. So in this case, I am going to show and use pilocarpine at the end of the surgery. Anita ji, अच्छे से हैं आप? And Namda, as you were saying, this patient I am doing synergy. She wanted only monofocal lens. And today only I discussed with again, then what should we do? She actually was posted for IANS live surgery today.
So
and when I discussed,
he got
he agreed to.
He got upgraded to synergy then, huh?
Yeah. No, she is ready. She is paying for it. And she accepted the advantage when the details were given to her again. She came with the family, son, husband, and both understood it better. So they accepted it.
There's one more question, Virendra, that if it is a surgeon, for instance, I'll give you two examples. If it's an orthopedic surgeon, would you do synergy? And if it's an ophthalmic surgeon, would you do synergy?
I have not done synergy in ophthalmology, but other surgeons I have done synergy, multifocal, trifocal, both. I would share one negative point which I was told by ophthalmologist itself. No other surgeon has come out with any complaint other way. But ophthalmologists say that whenever I examine patients on sit lamp on or on couch, they are seeing some images on that examination part also. So probably I'm not able to understand and answer it. If somebody can answer it, you, Rajesh, or somebody else can answer it. That is only advantage. But other surgeons are very, very happy with the thing. You can see that out of the 3 Purkinje image, one and the 2 others, the 1 Purkinje image is very much centered in the smallest ring of this lens, and the 2 are also within the ring itself. So this is the placement you need to achieve in all multifocal, symphony, synergy, or trifocal lenses for better outcome.
Okay, there is another question that you are such a surgeon, versatile surgeon, using lenses from all companies, and I know Mr. Jaswinder from J&J is also sitting here, but I'm sure you've not done a head-to-head comparison, but how would you compare synergy with Panoptics?
I've done some of the Panoptics, not against Panoptics, but that continuity was not there. And I feel the quality of vision is still not very good with Panoptics, as it was an issue with the restore also. There is no point against or for any company, but this is, I'm just sharing my own results and experience with the lenses. Last year we used almost 10 Panoptic lenses. The patients were having better than multifocal effect because they were doing more comfortable vision with the distance near and intermediate parts. But the quality of vision was some issue. that they are saying that I'm not very happy, and I think that is the issue. And I'm not against any company, but my first choice is not to have the lenses which block blue light, because some of the patients are not very happy. And when we started almost 15 years ago, this kind of lenses, blue blocking lenses, the patients were saying that you are saying I am happy because I am reading 6:6, but my quality of vision is not good. So some of the companies have done change in the material, that glistening part which was there with those lenses now not there as they claim. But the biggest advantage of this Technics group of lenses or the Technics platform, that is glistening free. So glistening also makes the quality, and that becomes very important when it becomes a multifocality. So with the monofocal lens also is a quality issue, but that is acceptable by the patient. When it comes to a multifocality issue, I think glistening should not be there. That is the first thing.
So, Virender, I would like to thank you for your time and for your contribution. I know you since your postgraduate days, and I know you how, I mean, it's a story in itself how a person can start from a scratch and make it so big as you have become, and it's become an institution in itself. Uh, I would like to congratulate you for that, and also for your excellent demonstration of the three cases, along with practical tips which are so useful. We've had, if you see in terms of YouTube Live and Facebook and Zoom, we've had one of the highest viewership today. And